afternoon, everyone, and thank you very much for joining today's CAP education session on Wilms tumors with Dr. Gino Summers. I'm going to pass introductions to POGO to Dr. David Malkin.
So thanks so much for joining. I wanted to welcome you on behalf of POGO, and you will hear why shortly, as this is really the first pediatric presentation for this webinar series, and it came through a major collaboration with POGO, Dr. Summers and the pathology, pediatric pathologist. So very briefly, just for those who aren't familiar with POGO, the Pediatric Oncology Group of Ontario, is essentially an organization that works together with the Ministry of Health as well as all of the pediatric oncology primary tertiary centers in the province and 7 satellites in terms of enhancing the delivery of care and establishment of guidelines, an integrated system of care, and access to resources for children with cancer and also for the system itself. And on this slide, you can see sort of the umbrella, which includes an integrated system of care with multiple centers, mechanisms for evaluation of delivery of care, which in this case would include the delivery of pathology services and reporting, and then there's a large parental and family shield for financial support and other aspects. The mission is outlined here, and there are many pieces to this mission, but ultimately it's really to have the delivery of equitable access of care and state-of-the-art cancer care for all children in Ontario, a very large geographic area, and that includes the delivery of state-of-the-art diagnostic testing where appropriate for children with cancer, sort of in the second bullet there. There's a number of other specific aspects of the mission that you'll see on the last side. We leave you with some contact information if you're interested in receiving. As I mentioned, it's really covers a broad number of institutions. Within the center of this circle, you'll see the 5 tertiary care hospitals in Ontario: Toronto, London, Hamilton, Kingston, and Ottawa, 7 satellite institutions around the province that are very tightly linked to these tertiary centers, and then a number of other institutions which work together with the entire system, with POGO as well. The operating principles are to really try to deliver the best care to the patients at the right time, the right place, and the right care, and often that means as close to home as possible. And equivalence of care and equity of access are the key points relevant to today's discussion. So, as I mentioned, are very closely work with the Ministry of Health and Long-Term Care in terms of developing partnerships with other institutions as well as with a variety of community partners, but we're also able to work with them and advising them in terms of financial considerations for new technologies that are relevant to pediatric oncology, new drug access, and new reporting systems for various scenarios. And then in the last slide really is to give you a slight background on what to this particular session is. We have had a provincial pediatric oncology plan which is reported to the ministry, as we are responsible to the ministry, and we developed, initially this was developed in 2006, but in 2011 rather, reestablished a number of the priorities, and front and center in that was the pathology and molecular diagnostic priority, with 3 recommendations being put forward that we are currently working on. One is establishing staffing parameters in the disciplines of pathology and molecular diagnostic. The second is recognizing ancillary testing and the to implement a funding stream for such testing in Ontario and presumably ultimately across the country. And relevant to today's discussion is a standardized reporting mechanism, and there's been a working group working for the last couple of years under the auspices of POGO to ensure implementation of these standardized protocols. And that will be the focus of today's discussion, with Wilms tumor being the test pilot, if you will. So I will end my comments there and leave you with the contact information through Jackie DeBeek at POGO, and of course we'll be also here to answer questions.
Thank you very much, Dr. Malkin. Dr. Strigley, are you on the line?
Yes, I am. Can you hear me okay?
Yes, thank you very much. I'll now pass over introductions to Dr. John Strigley. Thank you.
Thank you very much. Good afternoon, everyone. I'm Dr. John Strigley, Chief and Medical Director of the Program of Medicine and Genetics at Trillium Health Partners and the expert lead for pathology for the Canadian Partnership Against Cancer. On behalf of the Pediatric Oncology Group of Ontario, the Canadian Partnership Against Cancer, and the Canadian Association of Pathologists, I would like to welcome everyone to today's CAP checklist education session on pediatric patients with Wilms tumor. Before I introduce our speaker and we get underway formally, I'd like to take care of a few housekeeping items. First, the session is being recorded and will be made available to all participants via email links once the recording becomes available. Both the live presentation and the recorded presentation are eligible for CME credits. The information on obtaining credits was provided in a notice for the session previously distributed. Please note that CME certificates for each of the CAP checklist education sessions will only be issued for 1 month from the presentation date. Please refer to the session notice for the exact deadline date. Please note that everyone's line has been automatically muted for today's presentation. We have a large number of participants, so we can't troubleshoot any WebEx issues as part of this call. If you're having difficulties, please call the WebEx support line at 1-866-293239. We invite you to submit questions at any time during the presentation using the chat box feature. The documentation previously distributed provides instructions on utilizing the WebEx chat window. During the question and answer portion of the presentation, in order to avoid collision of questions, a CPAC staff member will pose the submitted questions on your behalf as long as time permits and in the order which they appear. In the chat window, please include the following information: the name of your institution, the name of the individual posing the question, and finally the question. It is my pleasure to introduce Dr. Gino Summers. Dr. Gino Summers obtained his medical degree from Monash University in 1991 and received a PhD from the University of Melbourne in 1999. He was anatomical pathology training with the Royal College of Pathologists of Australasia in 2002. He then went on to complete an 18-month pediatric pathology fellowship at the Hospital for Sick Children in 2004, and became a staff pathologist in 2005. And since 2013, he has been the head of the Division of Pathology at Sick Kids. He is an associate professor of pathology at the University of Toronto. Dr. is also involved in several research projects, including the utilization of high-throughput genomic technologies for diagnostic use, pathology and biology of undifferentiated sarcomas, and diagnostic biomarkers for pediatric rhabdomyosarcoma. Without any further ado, I introduce Dr. Gino Summers to give today's talk on pediatric patients with Wilms tumor and the utilization of the CAP cancer checklist. Gino?
Thank Dr. Strigley and Dr. Malkin for first those couple words and a few introductory remarks about POGO. I am going to talk about the most recent CAP cancer protocol for pediatric Wilms tumor. Before I go any further, I'd like to make some disclosures. Firstly, I have no financial relationships to disclose, nor will I be discussing any off-label use or investigational use during this educational talk. Objectives are fairly straightforward today. I'd like to review the CAP protocols as they relate to Wilms tumor and its use by pathologists, particularly those of us in pediatric pathology. And I'd like to also go over the changes in the latest revision of the cancer protocol. This second objective actually is quite straightforward. I think the only thing they've changed is the word checklist to case summary. So we've already achieved objective number 2. Now let's talk a little bit about protocol best. So that everyone's on the same page, the protocol I'll be talking about is the examination of specimens for pediatric patients with Wilms tumours, and it was published on the CAP website in June 2012. It's the latest of the protocols for Wilms tumour, and it's available at the website as there under the cancer protocols and checklists tab. So the tumours that are included in that protocol are obviously Wilms tumour, but you also use the protocol for several other pediatric, including rhabdoid tumour of the kidney, congenital mesoblastic nephroma, both the classical and cellular subtype, cell sarcoma, and indeterminate tumour types. So, for example, we have occasionally high-grade sarcomas of the kidney, which we use the protocol for. The only thing really that isn't covered in this protocol is renal cell carcinoma, and it's recommended that you use the adult RCC protocol if you do see renal cell carcinoma in pediatric patients. Today we'll be talking about Wilms tumour and how this relates to the protocol and how, at least how I interpret the protocol and how to fill out the synoptic report. Before I talk about the protocol and the pathology of Wilms tumour, I'd like to revisit some of the anatomy of the kidney, and what I'd like to focus on is the fascia, which you can see here outlining the kidney, the anterior border, and the posterior border. Fascia is an important landmark because when surgeons perform radical nephrectomies, they remove Gerotis fascia as the outermost lining of the specimen. Gerotis fascia is usually intact except at the medial portion of the kidney where the surgeon removes the hollow structures from the retroperitoneum, and it's sometimes disrupted at its superior portion here if the surgeon leaves the adrenal gland in situ. The Gerotis fascia it's an important structure to recognize in the explanted specimen, and it provides the pathologist with, as I said, probably the outermost or at least the soft tissue margin of the kidney. Having said that, let's handling of the specimen and what the optimal way to handle a nephrectomy for a Wilms tumour. Often we receive radical nephrectomies. Sometimes we receive partial nephrectomies, even wedge capsular resections. But we'll talk a little bit about the different resections later. Essentially, for a radical nephrectomy or any of those excisional biopsy samples, it is submitted intact by the surgeon. And I'm sure everybody listening who has worked in a pathology laboratory understands the importance of us receiving the specimen intact. We, at least myself, sample margins before inking, and the margins that I sample are usually the vascular and ureteric margins. So the renal vein margin, the renal artery margin, and the ureteric margin are sometimes incredibly difficult to find once everything is lathered in black ink. So they're probably the only exceptions to inking thing before you cut. So I try and sample the margins first and then ink. And certainly it needs to be inked before you bivalve the specimen. And once again, I apologize if I'm telling most people what they already know, but I think it's a point that needs to be emphasized. And you can differentially ink if you wish. I usually ink the specimen the one color, and the hilar or renal hilar structures and the renal hilum a different color. Just it allows for ease of recognition once it's fixed. Obviously, the capsule must never be stripped because you strip away then nephrogenic rests, which we will talk about. This is a good example of the reason why we like to receive specimens intact in the pathology laboratory. This was received intact. It was cut by us in the laboratory, but what you can see, the arrow the black arrow pointing to the right, is what appears to be a capsular rupture, but in fact it's just an artifact of having cut the capsule too thin, and it looks like tumour is bulging through, but we know because we inked it prior to cutting, there's no ink there, that's not a real margin, and that's something that you can only appreciate if it was received intact in the first place. Another clue here, you've got the adrenal gland sitting on the superior portion. You've got the hilar structures inked green. It's much easier to see. And in this oval circle is an area of hemorrhage around the capsule that, again, it's a good example of this is the area that should be sampled because there's hemorrhage and the capsule of the kidney appears to be ruptured, and that is potentially an upstaged tumour if the tumour percolates through there into perirenal fat. Just a good example of why we like to receive the specimens intact in the pathology laboratory. So as I mentioned, at least I sample the vascular and ureteric margins first. At least identify the sinus soft tissue margin, and the capsular margin, as I said, is usually durotus fascia, and that's the outermost layer of the kidney that we often receive with rectal nephrectomies. Before we talk specifically about the protocol, one more thing I'd like to mention is documenting the site of sampling. When the pathologist receives the kidney specimen with the tumour, it's crucial to document where those samples were taken rigor, so that if you do want to map a particular feature, say you want to map anaplasia or you want to map capsular rupture, you can go back to the specimen and do your macro-micro correlations. I like to sample the periphery of the tumour. That gives a nice interface between tumour and normal kidney, the tumour and capsule, and tumour and renal sinus structures. You can sample the centre of the tumour. Often I do one or two from the centre, but most of my samples are from the periphery of the tumour. It gives you a nice look at other structures as well as the tumour on top of that. Below, you can descriptively write down the block code in the gross description, or you can photograph it. And I find with big and complex specimens, photographically putting in the block code really helps when one goes back to the specimen for any reason for additional blocks. Remember, if we're talking about Wilms tumour, at the initial sampling, don't forget to take 2 blocks of normal kidney, looking for nephrogenic rests. They can be quite subtle, and I'll show you what I mean by that in a few slides' time. And multifocal tumours, sometimes we get resections from children with certain predisposition syndromes, and they present with multiple tumours at different sites. Sample them as you would any primary tumour. Photographically documenting the block code is a good way to make sure that you know exactly where that slide has come from. And this is an example of that. We can go back to this specimen with the block and know where certain blocks were taken from, and particularly in this instance there was, you can see here at the the bottom of the screen, there was a lot of tumour sort of in and around the renal vein, and it was easy for us to ascertain exactly to the extent of that renal vein involvement because of the block code. And obviously, too, you can see here we extensively sample renal sinus, which is that we look at because it's important for staging, which we will talk about as well. So in the CAP protocol, the first thing that one should note is it's fairly straightforward, obviously, but what type of specimen are we dealing with? Often, as I said, we deal with radical nephrectomy, sometimes with a small tumour or with a child where renal sparing surgery is the surgeon will get a partial nephrectomy. Obviously, specimen size and weight is important, and laterality is important as well. Once specimen is received, it's important to document the site of tumour involvement. Is it upper pole, middle, or lower pole? Sometimes with very big tumours, it involves all three, but usually you get a sense of where the tumour is mostly affecting. And sometimes you have a remnant lower pole or a remnant upper pole, and the tumours involving the other two sites. It's important at this point to have good communication with the surgeon. As I said, sometimes it's difficult to ascertain exactly where the tumour is and which structures it's involving, and here the surgeon is very helpful and you know, in some ways your best friend at trying to orientate the specimen and point out the structures that are involved from the surgical point of view. Tumor size obviously is important. I've not yet seen a tumour where I can't determine the size, but if it comes out piecemeal sometimes, I guess it would be difficult to determine. Mind you, I've not seen that occur, so size fairly straightforward. And focality too, is it unifocal? Most of the sporadic tumours, the Wilms tumours that we get as resection specimens are unifocal. There's only one tumour. In children with certain genetic syndromes, overgrowth syndromes or WT1 gene mutations, you certainly can get multifocal tumours. Occasionally you get a complex specimen where it appears there are multifocal tumours, but they all seem to join into the one confluence of tumours, and in that case it might well be indeterminate to know exactly how many tumours you're dealing with. The extent of the tumour is important. Obviously, the Gerotis fascia, as I said, is one of the landmarks that one looks at. More often than not, we see that Gerotis fascia is intact, at least in my experience. It's uncommon for it to be disrupted, but beware of a hematoma. You see radical nephrectomy, there is an adherent hematoma. That is a site that is well worth sampling thoroughly, because that could easily hide disrupted tumour that ends up hemorrhaging through the fascia. Renal sinus involvement is another anatomic landmark that is important, firstly to recognize, and secondly to document the extent of tumour involvement. Simple stage 1 tumours, the renal sinus is not involved by the tumour, minimally extend into the renal sinus soft tissue, but not involve any of the vessels within that renal sinus. And the other two categories there are where the tumour extensively involves renal sinus soft tissue, and that's easy to see macroscopically, or it involves lymphovascular spaces, and sometimes you can only see that microscopically, or if you have a big tumour plug in one of the major branches of the renal vein, for instance, that is something you can see macroscopically within the renal sinus fat. You that this is the anatomy, Gerard's fascia, renal sinus with the renal pelvis within it, and the renal sinus fat here. And it's important to sample this area thoroughly, particularly with any tumour that tends to sit around the mid-portion of the kidney, or any tumour that's in one of the poles that appears to be bulging into that renal sinus fat. This example of extensive involvement of renal sinus soft tissue by Wilms tumour. You see here is the tumour mass. It's sitting predominantly within the mid-portion of the kidney. And you can see here, this is renal sinus fat here around the pelvis, and you have a big area of tumour involvement here toward the lower pole, and here's the ureter that's a little twisted, but it should be running inferiorly there. So that's an example of extensive involvement of renal sinus. Here is what looks to be less obvious involvement. This is a post-treatment tumour. You have the tumour sitting here within the mid-portion of the kidney, within that renal sinus soft tissue, and the margin here is obviously going to be very important. Sample, and it looks as though there is some structure within the renal. This is renal vein here. It's as though there is focus there of plugging within the vein. So once again, it's important to look at your renal sinus structures that may well be involved by tumour. We're still on macroscopic extent of tumour. Does it involve the renal vein? Macroscopically, you can sometimes see that, although on occasion it's difficult or it might be subtle, and it's worth sampling well the renal sinus. And at least in my practice, if I sample the renal sinus thoroughly, I know I will get some of those blocks containing a portion of the renal vein, and that's a nice way of determining if it is involved by the Wilms tumour. Indeterminate or cannot be assessed. Occasionally you get tumours that are so large that they obliterate the structures within the renal sinus, and we've had a few of those here. It's where it's a bit of a challenge to determine exactly what the tumour is involving. Adjacent organ involvement is fairly straightforward. Does it extend into adjacent organs or not? And that often means the adrenal gland. That's the adjacent organ that we get in a surgical specimen. If adjacent organs are involved, the surgeon often see that at the time of surgery. We had adherent bowel involved with Wilms tumour, for example, and that's come out as a partial colectomy. So adjacent organ involvement obviously is something that's seen surgically, but occasionally you'll see involvement of the adrenal gland that may or may not have been ablated prior to surgery. One thing about the renal vein margin that has, it took me a little while to understand this, but the renal margin, when it's positive or negative, depends on if that actual cuff of this vessel that's been cut is involved by tumour. And I want to show you on the left-hand side, you can see a tumour plug here, schematically in red, that sits in the renal vein intact. It's not broken off at the end, and the surgeon will certainly help you in determining that. Yes, I removed the thrombus intact. And the actual, you can see here, the ends of the renal vein at the top and the bottom are not involved by tumour and are well away from that tumour plug. So this is, in fact, a negative margin because you're looking at these two margins here and you have an intact tumour thrombus. So that's negative renal vein margin. A positive margin would mean that you have the endothelium, or the vascular structure, tightly adherent to that tumour thrombus at the margin of excision, and that suggests then that what's left in the patient has some adherent tumour. So that's considered a positive margin, as well as if any of this thrombus cannot be removed, or if there is thrombus further proximal within the renal vein or the IVC. And we've had a few instances where the surgeon can't remove more thrombus without involving major vascular surgery. So just a note here of what a negative margin is and what a positive margin is. And I think the take-home message is you can have protruding tumour thrombus, but still a negative vascular margin. Types, here, as I said, there are many different pediatric tumour types that apply to the Wilms tumour protocol. Wilms tumour being obviously one of those in the histologic type, as well as the mesoblastic nephromas, clear cell sarcoma, and rhabdoid tumour, and occasionally other types. As I said, probably the only type of tumour or histologic type of tumour that we don't use this protocol for in the pediatric population is renal cell carcinoma. Histology, and I apologise again to those of you who know this, but I think it's a good exercise in what are some of the histologic subtypes and how we approach them when we're talking about the protocol. This is just a nice overview of a Wilms tumour. You can see the fibrous capsule separating tumour here from compressed and scarred kidney on the right-hand side. This is a treated tumour. You can see foamy macrophages and nests of blastema and immature tubules. So, one of the keys in recognizing a Wilms tumour is that it does form this quite fibrous capsule that separates it from the kidney. The blastema in a Wilms tumour is round, plump spindled, and often very mitotically active. I think you can all recognize here those very dark mitotically active cells. And in between these sort of serpiginous islands of thema, you find that undifferentiated mesenchyme, which is the stromal component of Wilms. Just showing mitotically active blastema and that primitive-looking mesenchyme at the top left of the screen. The third component, Wilms being obviously triphasic tumour, is the epithelial component. You can see that there, it's quite hyperchromatic, forming primitive tubules and some vague glomerular-type structures. Which, as I said, is often mesenchymal-type cells, can sometimes show evidence of heterologous differentiation, which you see here in the form of these very plump pink cells. This is showing rhabdomyoblastic differentiation. In the higher power, all these plump pink rhabdomyoblastic cells, and that is something that we sometimes see in the stroma of Wilms tumour. It doesn't really affect prognosis, it's just something to recognize. These elements can also affect the epithelial component, and you can see here the area of squamous differentiation within the epithelium. One of that is important to recognize is anaplasia, as it is a prognostic factor. You can see here blastema, which are these very dark islands of cells. You have stroma in between those islands. But one of the things to note here is you have very large atypical cells, and they have to be hyperchromatic and at least three times the size of neighboring cells, which they appear to be. They have abnormal tetrapolar and pentapolar mitotic figures. In this case, abnormal mitoses is the other features. So very large hyperchromatic cells and abnormal but other recognizable mitotic figures. View of that, confirming these very large cells that are easily 3 times the size of its neighbours. It is divided into focal and diffuse. Diffuse anaplasia is seen at multiple sites. Focal anaplasia tends to be seen only in one or a few sites and usually is surrounded by otherwise non-anaplastic favourable histology Wilms tumour. For it to be called focal anaplasia, it needs to be limited, as I've just said. In addition, should not be present in extrarenal sites or in any of the extrarenal vessels. If you have a lymph node, for example, with anaplasia, then by definition, it's diffuse anaplasia, for example. And that's the normal mitotic figure, again, a figure of anaplasia that we look for. The uses of Wilms tumour that we look for is nephrogenic rests. And nephrogenic rests are essentially of 2 types. There's the interlobar rest and the perilobar rest. The perilobar rest tends to be the more common of the 2, intralobar less common, and they have specific genetic feature you should alert a clinician to if you do see them. Aplastic rest will masquerade as a Wilms tumour. It's a very big rest. It looks cytologically like a Wilms tumour, but it does not have the fibrous capsule which we spoke about before. But they can be very challenging, those diffuse hyperplastic nephrogenic rests, to separate from Wilms tumour. And remember, if you see a needle core biopsy from a Wilm, which are certainly uncommonly done in our institute these days, but if you see a needle core biopsy, you cannot differentiate a Wilms tumour from a nephrogenic rest on cytology alone. One needs to see the architecture, specifically its interface with the normal kidney. Just a schematic diagram of the 2 types of nephrogenic rest. The perilobar rests usually sit just beneath the capsule, and that's why it's not a good idea to strip the capsule, or it sits at the periphery of the functional renal lobule. You can see here it's just sitting right at the edge. They tend to be quite well circumscribed, the perilobar rests, and they're composed predominantly of blastema and tubules, usually associated with the overgrowth syndromes that we see. The interlobar nephrogenic rests, on the other hand, tend to be more within the functional renal lobule, which you can see here. They're composed predominantly of stroma rather than blastema and tubules. They are less well circumscribed. They tend to be a little bit more irregular and intermingling with the normal kidney, and the rests that we see associated with WT1 type mutations in patients. Well, here you've seen this picture before, and I'm sure those of you who were looking at this closely would have recognized here, just beneath the capsule, you can see these pale areas that are indeed nephrogenic rests. These are perilobar because they sit just beneath the capsule, and they're important to recognize and to sample. It's a little more subtle. You can see here a treated tumour with areas of hemorrhage and necrosis. But if you focus in this area here, I'll show you a slightly higher. You can see this faint pale mottling, and sometimes the rests are easy to identify, other times they are not, and I emphasize that it's worth sampling quite well the normal kidney if you're at all unclear. This is a example of a perilobar nephrogenic rest sitting beneath the capsule. You can see here it essentially is very well circumscribed, and there's no fibrous capsule beneath between nephrogenic rest, which is composed here of essentially immature tubules and some blastema, and the normal kidney that sits next to it. Just again confirming the lack of fibrous capsule between it and the kidney. And although that nephrogenic rest was obvious, some nephrogenic rests are quite subtle, and this was one that was picked up almost fortuitously, sit beneath a diathermid and disrupted capsule. So look carefully for these little nests of immature tubules and blastema, because sometimes they declare themselves macroscopically. Really, just to remind me that the interlobe arrests, which are much less common, have predominantly stroma-rich appearance to them, and they can certainly show some differentiation and often give rise to stroma-rich Wilms tumours, whereas the perilobe arrests usually give rise to the more classic triphasic blastemal predominant Wilms tumours. We've spoken about now the histologic subtypes and to a degree nephrogenic rests. I'd like to talk a little bit more about the margins, and margins are important when it comes to staging. Margins should be looked at closely, both vascular and soft tissue margins, and the measurement of the closest margin usually given in centimetres, and then obviously specify the margin. Gerotis fascia is sometimes the closest margin as the tumour abuts that as it sort of grows outside the normal anatomic confines of the kidney. The renal vein margin will be the closest margin. I take that to be the distance from that uninvolved end of the renal vein to where it joins the actual tumour thrombus. Having said that, tumour thrombus poking out of the renal vein often means that the clinical team need to look carefully for distant spread. Does it involve the inferior vena cava? On occasion, we've had more major surgery where renal vein and a portion of the IVC has been removed. Ureteric involvement, at least in my experience, is uncommon. And for any other margins that are seen to be involved, that's important to know too. For example, sometimes Wilms tumours that grow into the renal sinus fat and the hilar area, it can be difficult to sort of get a clean margin. That's important to sample as well. We often get lymph nodes separate to the kidney. The surgeon removes the kidney and then removes the lateral lymph nodes within the drainage area of that kidney involved by the tumour. Lymph node metastases are essentially fairly straightforward to identify. Can be a little challenging, and often it's worth looking very closely within the subcapsular sinuses of the lymph node. Blastema can look very much like a cluster of reactive lymphocytes if they're small clusters. And it's certainly worth paying extra attention to the area of the lymph node just beneath the lymph node capsule. If in doubt, WT1 staining is very helpful. To the separately submitted nodes, occasionally you'll see nodes around the hilar area that are worth examining as well. Number of nodes should be specified. Occasionally with very big lymph nodes or groups of lymph nodes that mat together, the exact number cannot be determined, and in that case I say group of nodes, number undetermined, with involved by Wilms or not involvement by Wilms. And essentially, that's something that the clinicians will be aware of, imaging studies will be aware of, and the pathologist should be aware of those if wanting to stage the tumour. Additional pathological findings are important to note, particularly in the kidney that is sampled, the normal kidney that is sampled in addition to the tumour. Additional pathological findings certainly help clinicians in determining if there's any primary renal disease in the contralateral kidney that needs to be followed up. Comments. I like the comment section in the CAP protocol because you can put in the comment section certain points or certain features that you like to highlight that aren't highlighted or have no equivalent area within the actual protocol. So I use the comments quite liberally if I want to make a point. For example, if I want to comment on the presence of intralobar rests and the possibility, therefore, of WT1 mutations, lobar rests, and the possibility of the contralateral kidney being involved. And you can imagine the type of comments that you could put in if you so wished. So the staging of we use is that we use for renal tumours, as I said, other than renal cell carcinoma. And a stage 1 tumour is basically limited to the kidney and completely resected. There should not be penetration of the renal capsule by the tumour. There should not be involvement of lymphovascular spaces in the renal sinus, and there definitely should not be any metastases to renal lymph nodes. So it's essentially a well-contained tumour within the kidney that's completely removed. And as opposed to a stage 2, stage 2 again is completely resected, but it extends beyond the margins of the kidney in that it either extends through the renal capsule, but obviously with the negative resection margin. It involves extrarenal or renal sinus lymph vascular spaces, and it involves the renal vein. But as I said about the renal vein margin, that margin is negative. And it can extensively involve the renal sinus soft tissue as long as it doesn't involve the margin. And I just have a slide here to show you what renal cap involvement looks like. And you can see here the Wilms tumour. The renal capsule is sitting above it in pink. And you can see here you've got tumour percolating through that capsule. And here's the capsule here, and if you do the horizontal line test, you can see that that extends beyond the confines of that capsule. Even though it is a bit thickened here, it's sitting outside the confines of that capsule. So that's renal capsular breach in a Wilms tumour, and it's at least a stage 2 then. 3 means there's a very high likelihood of residual tumour, and that includes tumour being present at the margin of resection. Tumour capsular rupture is identified. Sometimes the surgeon will mention that there was capsular rupture at the time of surgery, or sometimes the pathologist will identify it as an area of hemorrhage, subtle or otherwise, at the gyrus fascia. And as I said, tumour spill before or during surgery, on occasion big and necrotic tumours that may occur, and that upstages it 2 or 3. Peritoneal excision of the tumour, which in my experience is uncommon, but that would to be a stage 3, and the tumour in regional lymph nodes obviously also causes it to be a stage 3. And don't forget that if there's a history of a renal tumour biopsy before the definitive surgery, then automatically it's stage 3, regardless of how well confined that tumour is to the kidney. The last two stages are fairly straightforward. Stage 4 means there is metastatic disease, be it in lymph nodes, outside the abdominopelvic region, or hematogenous metastases. And stage 5 is bilateral renal involvement at diagnosis. And the protocol states that you need to, even though overall it's a stage 5, you need to stage both the right and the left kidney as that relate to each of those specific tumours. And often these children with stage 5 tumours have genetic predispositions and nephrogenic nephroblastoma. Essentially, the CAP protocol, as it is for pediatric Wilms tumour, before I take questions, I'd like to thank the authors on the CAP protocol. It's a list of very distinguished and very accomplished pediatric and renal pathologists, and they put a lot of work into the protocol. It certainly made signing out the tumours a lot more straightforward. I'd like to thank my colleagues from KIDS who helped with the images that I've shown, Drs. Thorner, Taylor, Chung, and Nan. I'd like to thank the people of POGO who made this possible, David Malkin, Corinne Greenberg, and Nicole Bradley, and the people from CPAC, Ms. Wilms, and Dr. Shrigley. Thank you very much. Happy to take questions.
Thank you much, Dr. Summers. So we're going to take some questions now, and as Dr. Shrigley mentioned, if you could please type in your question in the chat box with the name of your name and the name of your institution and your question. So I have a question for Dr. Summers from POGO, and the question is, if Dr. Summers can please comment on the implementation plans for the standardization of reporting of pediatric protocols in Ontario, including Wilms tumor and other pediatric tumor types.
So through the efforts of POGO and my involvement with POGO, as David Malkin said at the beginning of the talk, one of the three areas that were recognized as needs in pediatric pathology was synoptic reporting and standardized reporting for pediatric tumor specimens across the province. And I'm sure I'm preaching to the converted, but synoptic reporting has a lot of strengths in that a lot of the information is then standardized. One of the things that through my involvement with POGO that we'd like to do is from our Wilms tumor synoptic reporting to other CAP protocols that have been written for pediatric tumors. And I think there's 6 of them currently, Wilms being one, neuroblastoma, Ewing's, rhabdomyosarcoma, hepatoblastoma, and germ cell tumors being the others. And I think that, eventually we would like to see synoptic reporting for most, if not all, of those tumor types, as well as osteosarcoma, which is right now under the adult synoptic reporting. We'd like to do this, obviously not just at one centre, but through most of the tertiary or of the tertiary centres in the province. How we implement that with different sort of systems and computer software is something we're looking into, and certainly we understand that none of this type of software and infrastructure comes free, so we're looking at some way of funding institutes in implementing the ability to incorporate synoptic reporting in the sort of seamless fashion possible. And we'd also like to sort of increase our, I guess, knowledge translation activities in, education sessions such as this, perhaps at a more local institutional level, helping the clinicians understand the importance of synoptic reporting and what might be coming down the pipeline in the near future. One of the other things that we'd like to do is assess I guess the success or the uptake of synoptic reporting, at least hospital by hospital, to see if A, the clinicians notice a difference, and B, does it make it easier for all the other people that read the report, be it for clinical or research trials, does it make it easier for them to extract the information that they need? We're more than happy to take any ideas from people out there who've been through this already for the incorporation of synoptic reporting. So, cut a long story short, I think POGO is central to us rolling this out throughout the province and in helping educate people, not just pathologists.
Question is from David. Do you find blastema predominant cases where there is little stroma do worse than conventional Wilms?
That's a good question, David. We see that I think there's been a few mixed messages out there as to, blastema predominant, does it do worse or better? In my experience, I must admit, I haven't noticed much of a difference. We don't. Most of my Wilms tumours that I've seen, mind you, tend to be blastemal predominant. Maybe I've got a skewed view, but I think the jury's still out, really.
Question is from Diane, and Diane would like to know how many additional blocks are necessary when you have capsule penetration but not through the capsule.
If I understand the question, it's if the tumor extends into the capsule but not through the capsule. So that's a very good question, and the protocol has. It does address it to an extent, but there is a very nice summary of what Dr. Perlman calls the horizontal test, where if you've got tumor that extends into the capsule, often what happens is that at the advancing front of the tumor, you have fibrosis and inflammation. And it's sometimes difficult to ascertain whether that fibrosis and inflammation is that part of the capsule or is actually tumor capsule and it's penetrated beyond it. So I look at the adjacent renal capsule, and if the tumor appears to be extending beyond that, if you draw a horizontal line and tumor is extending beyond that but still within some sort of fibrous tissue, I call that capsular rupture, and it's therefore into perirenal tissues. But I think that no box is really a personal preference. If I see an area that looks hemorrhagic or looks like it's penetrating the capsule, I'll take as many as I need to feel happy that it's not penetrating or I've shown it to be through capsule. And often, depending on your size of rupture there, it can mean blocking extensively. We're talking sort of 5, 6, 7 blocks of that area if you need to.
Very much, Dr. Summers. Do we have any additional questions? I'll wait a moment. Okay, from POGO. What elements need to be reported of rhabdomyoma is suspected? So what extra elements need to be reported of rhabdoid tumor is suspected?
So if you're suspecting rhabdoid tumor, I think the protocol pretty much covers everything they would need to include in that report for rhabdoid tumour. Obviously, the question then is, have you made the diagnosis of rhabdoid tumour? And I'm assuming that you have with the histology and the immunophenotype. I don't believe, other than what's in the protocol, I think most of those elements that you need to report are incorporated into the CAP checklist. So follow the protocol, and you should be missing any of the major features that you need.
Are there questions? Would like to say this was an awesome talk.
Thank you, David.
If there are questions, I'll now put the call back to Dr. Strigley, who will give our closing remarks.
Thank you for that wonderful talk. Just a few general comments. One of the big issues in renal tumor pathology, of course, is the staging issue in the renal sinus, and the pediatric pathologists and the work done by the National Wilms tumor group years ago really sort of opened the adult surgical pathologist's eyes to the importance of the renal sinus, and I think that will be addressed in the new TNM-8, which comes out in 2016, a better stratification within renal cell carcinoma. The importance of the renal sinus will be included in that staging system. Another comment is that with respect to the CAP Cancer Committee, on which I sit for the Canadian Association of Pathologists, we do have a new pediatric pathologist that started this year, Erin Rodzinski from Seattle, and she'll be the person that's responsible for the minutes and updates of the pediatric protocols on a go-forward basis for the next several years. The third point is that recently CAP has separated the synoptic reporting of biomarkers to a separate subcommittee of the CAP Cancer Committee, and they've set out guidelines with respect to a number of the adult biomarker reporting templates, such as EGFR, etc. And I suspect that a similar thing might happen for the pediatric ones for those tumors where you have separate molecular biomarkers that are important in terms of going forward with stratifying patients both on the morphological side and the biomarker side. I think that was in part done because some of the biomarker testing, of course, is done by institutions where the primary pathology is different from the primary pathology. So I think CAP felt really that they wanted to have a separate synoptic biomarker checklist for that situation that could be actually integrated with the main synoptic report that relates more to the anatomic histological features. So those are just a few general comments from the CAP Cancer Committee. But just to finish up, on behalf of the Pediatric Oncology Group of Ontario, the Partnership Against Cancer, and the Canadian Association of Pathologists, I really want to thank you, Gino, for a truly comprehensive, very well illustrated, informative, and clear presentation today. This is the fifth session of the 2014 series of CAP checklist presentations, and we would welcome your comments and suggestions for ways to ensure these sessions are informative and relevant to your practice. Please include your feedback and suggestions as to the complete online evaluation. Once the WebEx recordings of this presentation become available, they'll be made available widely through links from POGO, CPAC, and the Canadian Association of Pathologists. Access to this recording will be available for review at your convenience and is not restricted. As a reminder, both the live and recorded presentations are eligible for CME credits. Please see the initial session notice for more information. Please note that CME certificates for each CAP checklist session will only be issued for 1 month from the presentation date. The set will remain available electronically for an undetermined period of time, but CME certificates will only be issued for 1 month. Please refer to the session notice for the exact deadline date. Once again, this is the last session in the 2014 schedule for these CAP checklist education sessions, and I thank you very much for your attendance.